Late nights, skipping the cleanse routine, going to bed with your makeup on. We can put our skin through a lot over the years. Thankfully, Cotia has combined Deer Milk with powerful actives to create skincare that genuinely keeps up with your lifestyle. And thousands of Aussie women are already obsessed. Keen to see what all the fuss is about? Use code MAMAMIA20 for 20% off your order. Cotia, because your skin deserves something extraordinary.
Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Well, welcome everyone. I'm Brigid Maloney, and today we've got a guest on talking to us all about breastfeeding. It's Dr Kavita. Now, she's a breastfeeding medicine specialist. She's a perinatal GP, an IBCLC, and she has over 18 years of medical experience. So she really started firstly in paediatrics, and a community health rotation sparked her interest in supporting postpartum families. She's so passionate about supporting the postpartum family. So she went back and she trained in general practice. She's also a lecturer at the Women's Health Department of UNSW, and we talk about that a little bit. She is a Thompson Method practitioner, NDC accredited, and a member of the Academy of Breastfeeding Medicine. She sits on the RPA, so that's the hospital in Sydney, Antenatal Shared Care Board. She contributes to the WHO's FIDES network and serves as an expert consultant on several national perinatal care initiatives. As I said, she is so passionate about addressing the overlooked challenges of the postpartum period and advocating for us all for a better evidence-based care for new families. So we talk we've made 2 parts of our talk with Kavita. The first is sort of like a basic overview. We ask her some questions about the anatomy of the breast and how to get a good latch and what are some of the myths surrounding breastfeeding. And then in part 2, we do a bit more of a deep dive on mastitis. So I'm so grateful for Kavita's time today, and I hope you really get something from our talk. Well, welcome, Kavita. I'm so pleased that you have joined us today.
Thanks for having me. I'm so excited to be here and to be chatting with you. Yeah.
I know. We had a bit of a false start, didn't we? We went to record this a few months ago, but the tech didn't work. So today we're all set up. We're triple recording, so it'll be fine.
But it was also, we had a great chat, remember?
Yeah, that's right.
Ages ago, we had a chat for an hour just about everything. So, yeah.
Well,
opportunities to talk.
So what we're going to do is do 2 parts today while we've got the brain of Dr. Kavita. We're going to talk sort of more basic about setting up for breastfeeding and the common issues that people have. And then we're going to do a part 2 deep dive on mastitis because, I'm sure a mama in the middle of the night who's thinking that she might have mastitis will be just searching the internet for that information that you can give there. So when we're going basic, let's start really basic. Can you tell me about the anatomy of the breast and how it all works to produce breast milk?
Yeah, so the breast is composed, it's actually a gland. It's got a glandular system, which I don't think we're really taught about, and it's a modified sweat gland. And so the major structure of the breast, you've got I always have a diagram that I use for this. Anyway, let's draw it out for you here. There's the nipple. You've got fat here, these little globules. Then you've got the glandular tissue, which are like clusters of grapes, which are connected by the milk ducts to the pore openings over there. And then you've got connective tissue, which are these little lines that give it its shape and structure as well. So that's the essential kind of the big, if we break it down to the macro kind of components of the breast, those are the big 3. But then there's so many more interesting things within the glands and even within the milk ducts and even in the nipple pore and the areolar skin there. But that's the basic structure of the breast as it pertains to how are we going to make breast milk.
God, that has just blown my mind. It's a like a sweat gland.
I know. I was like, should I give it a pause there? It's a modified sweat gland.
Wow.
Yeah.
Yeah.
So interesting how even different animals have different types of, like, I never thought about this before, right? Like I was doing some research on the nipple areola anatomy because we don't have anything out there, right? Like, so like we can give you lots of stuff about the dermis and how to get rid of our wrinkles and things, which is great. But we don't have detailed information about why the nipple areola skin works a certain way. And in reading about this, I went and had to look at all different mammals, right? So all mammals will have to have some way of getting this breast milk out. And so platypuses and echidnas have a different system where they excrete it and it gets licked. And whales have a completely different system because, of course, if they're in the ocean, how do they? So it's fascinating.
God, if we secreted milk and all the baby had to do was lick it, that would prevent so much pain and discomfort from nipple damage, and which I'm sure we'll get into.
But it's really interesting though, because the reason why ours are so dependent on that vacuum is because we're one of we're the most vulnerable. It's a nice way of putting it. Of all the mammals in the animal kingdom when we're born. So every other animal, even our primate cousins, can all hold on to their mothers. We can't. So we literally, the only thing we have, and it's remarkable how strong it is the ability to, these muscles are really quite strong, the tongue muscles, the cheek muscles, the orbicular around here, you've got these circular muscles around your mouth, which allow you to, pucker and things like that. They work together to allow the intraoral vacuum, which moves the milk from the breast into the baby's mouth. So we have a really strong suck reflex, which causes a lot of confusion for people because babies suck for other things other than hunger.
Yeah.
So,
another thing where the mother and baby are such a unit. Like the synergistic unit. Yeah, you're designed together. Mm.
And even I think I'm so amazed. The more I learn about the placenta, I think this is all like Dr. Pat stuff too, right? But the more you learn about the placenta and the adaptive mechanisms of pregnancy, even, it's just remarkable. And what's the thing that gets me every single day is how have we got to a point where we dismiss and we don't recognize the enormity and how it's like, it's mind-blowing,
Yeah.
But it's so common.
And it's so common. And why don't we I understand, why don't we have the mother-baby unit as primary focus?
As revered.
Yeah, as revered.
And our species got here on the, and look, this is not because I'm obsessed with, I didn't even want children. My children know this, I wasn't even sure I was going to have babies. So this hasn't come from I had a lifelong obsession with having children, but it's actually just the science of it, which is incredible.
Incredible. All right, back to the anatomy of the breast.
Back to the anatomy, yeah. Let's go back, yeah.
So you've mentioned the areola. Can you just describe what somebody, just from the basics, what does a breast have? What are the anatomical bits that people need to know?
So we've got the nipple, which is the bit that can protrude out, but we have many variations. We have 10 to 20% of the world will have a variation in nipples, which is 665 million. So if you're listening to this and you have inverted nipples or you have flat nipples, it's not that unusual. But that's the bit that protrudes off. It can protrude off the areola, and we have nipple pore openings in there. So usually around 9 to 12 openings, and that's how we get the milk out. Then that other different coloured bit was the areola. And that can be a variety of colours. And humans also have different coloured areolas, which is not as common in the animal kingdom. So that's also interesting. And then you've got the breast, which is the ones that we know about.
And I just want to pick up on different colours of areola. There's a fair-skinned areola. Are you more prone to nipple issues than a dark-skinned areola, or does skin tone not matter?
So we can't avoid getting to the meat of this, can we? No, there's absolutely no difference that we know of yet. But a lot of that is based on racist ideas and sexist ideas from the early 1900s that different people had different areolas. It's all got to do with the generational knowledge that was passed on, and then what was happening in that society. So, I don't know how many areolas I've seen at this point, but we know more than at least 10,000. And wow. there is nothing where and breast surgeons and stuff would see way more than me. But there is no reason why one will find it more difficult than another. It's got to do with other things, actually. The breasts get blamed, and for me, that's part of that misogyny in society, right? Like, let's blame it on the woman. Let's find a way to make it her anatomy. That's a problem, or her physicality that has, not achieved or been able to do something, but it's not the case.
Oh, I'm sure so many people listening to that would really like to hear that, because there's even women with small breasts or bigger breasts, or do any of that matter?
Yeah, so that's actually really interesting, because there's an assumption, and I have a lot of larger breasted women that come to see me, and I mean, the whole gamut of variety, but they've got this, everyone's been putting pressure on them. You're going to, they're milk jugs, you're going to have no problem, like, a lot of pressure.
Yeah.
And they're like, why isn't it working for me? So what's really interesting is, do you remember that first thing where my awesome diagram here with the fat, these little globules here with the fat, and this was the gland. So when you've got larger breasts, you've actually just got more fat tissue, right? We don't necessarily have any extra glandular tissue until we are pregnant. And what that means is that if you have too much, like a lot of fat tissue, that can actually compress the glandular tissue. So that can prevent the glandular tissue from being used as much as it could. So we can actually see that if you've got larger breasts and it looks like you should have lots of milk, then you may have the same issue as someone who may have a particular type of smaller breast. Smaller breasts and larger breasts, there's no difference in capacity. We've seen you'll still be producing, and this is the fun bit, at least 750 to 900 mils of milk a day to provide your baby.
As soon as you said that, I was like, yay, women. That's a lot. You're a legend.
And you know how we were talking about that incredible unit a bit back before, and I was saying about how in pregnancy, the placenta is what actually primes the glandular tissue of the breast to prepare you for lactation. So I'm obsessed with placenta. It's just because, like the analogy I always give is, if somebody walked out and they'd grown a new arm, you'd be like, wow, you've been doing incredible things. Whereas when a woman or a fat is pregnant, they have grown not just a baby, right? They have grown an entire organ.
Yeah.
And we're like, oh, it's no big deal. Yeah, keep working. Yeah, it doesn't matter if you're vomiting all the time, or, get back to your functionality. And they've actually grown a whole organ. And that organ is what it does so many things, as you know. Right?
Yeah, we've got a couple of podcasts on placenta, but I just want to, while we're talking about a placenta, we had a question about placenta encapsulation, and Dr. Pat's not a big fan, and he gave his reasons, but I just wanted to hear from you. Does consuming your placenta in any way help with breast milk supply?
We haven't got any evidence to say that it's harmful or helpful. I am a big fan of following what would be natural. So, if we're going back 10,000 years ago, you wouldn't have encapsulated it, right? But if it's your culture to consume it, you can definitely do that. And, maybe that helps with, I'm not across the research, but if it helps with postpartum recovery, but it could do that. But no, for breast milk, there's no evidence that it's going to help you with your supply. In fact, it's got, I don't know if it still has the ability to release progesterone, when it's not in the body anymore, but that inhibits prolactin and your milk supply. So I don't think any of those things. And Dr. Robin Thompson, who is a midwife who created the Thompson method, she had seen a lot in her, vast, like 60 years of experience, that sometimes that actually causes irritation for the baby. So my stance on it is, I don't have evidence for or against it. I think if it's really important for you to do culturally, please go ahead and do it. But if you don't expect that is what is going to bring in your milk supply. And that goes for everything.
Yeah. Good.
Struggling with the anxiety that comes with adulting?
Or maybe you've suddenly become the parent to your parents.
Wondering if you might have ADHD, but unsure if or how to get a diagnosis?
I'm clinical psychologist Dr Anastasia Horonis,
And I'm Ashani Dante. We're your hosts of But Are You Happy?
bringing you all the self-development and mental health information you actually need,
New episodes drop every Saturday morning.
just in time for your hot girl walk.
So tune in to But Are You Happy? The podcast where overthinking finally gets the spotlight it deserves. Made in partnership with Medibank.
Well, I want to get on to the latch. I'm a bit obsessed by the latch because I had 4 boys, and I know this is just a sample of me, and each one had a different latch. The last one was the worst latch, and you would have thought that I would have been able to just throw him on the breast and off I go, but he had a kind of real grinding motion and he'd get my nipple in his mouth and a lot of nipple damage. But tell me, how does somebody set themselves up? Is it somebody who's about to have a baby? How do they set themselves up, or what is the first breastfeed or the first week like for them?
Sorry about that. It's awful having pain and especially that nipple pain. It's one of the most innervated areas, right? And
I should have seen a lactation consultant back then, but I thought they're just going to laugh at me, my fourth baby. But yeah, I should have. Yeah,
it can be very common. And even you can have. I remember my first 2 were quite close in age, and I remember he had self-weaned by about, I was probably about 4 or 5 months pregnant, and I remember looking at somebody else breastfeeding and being like, how do we do that? And I literally had just stopped like 3 months ago. So you can forget very, very quickly all of that kind of stuff. So your question was how to prepare yourself.
Or how to prepare yourself, or what would you like people to know about how to get a good latch?
The first thing I look at it all holistically. So it's not just about the latch. This is an area which is completely obfuscated in our general knowledge. We've lost the generational knowledge. It's not there in the medical systems. So you have to approach having a baby and understanding a baby. So I always say you need breastfeeding and newborn knowledge. You can't do one without the other. The best thing to prepare for latch, and I will get there eventually, is you must understand your breasts. You must understand how they work. And it's simple stuff. I'm always like in science, do you remember they taught us like photosynthesis or like
osmosis?
Osmosis.
Yeah.
Osmosis. That's always my favorite one, right? I'm like you could have just taught us the breast or our periods instead, right?
Cycle. It would have been so good for people to know their menstrual cycle properly. Yeah.
That's right. And everybody, like men and women, right? Like, wouldn't that be useful? Like, if everybody had that, that's how you start that respect. So you have to understand your breasts. Because a lot of the stuff, like, I don't hear it as often now, but even the thing of like, you have to prepare your nipples, you have to toughen up your nipples, all of that is complete nonsense. Even now you'll see people like hamburgering and there's a flipple, there's all this kind of physical manhandling of the breast. Yeah. Which if you understand the principles and you understand your baby, you don't need. So understand your breast first, then understand the newborn infant and what they're capable of, what they need. And then I also say to understand the principles of swallowing. So I have like 3 things, and I've got these like on posts on my Instagram where it's how what is the breast? How is breast milk made? And then how does milk transfer from breast to baby? And I think my sister's not like me at all. So she's like, this is super boring. Can you tell it like while you're like making a coffee or doing your nails or doing some makeup, right? It is information dense, but you don't expect yourself to understand it straight away. And just remember that it's not in medicine. Doctors don't know this stuff. So how could you be expected to know it? So the key things that you need to know is how does the breast milk get made? So you must understand that it is that regular stimulation. So I think we've kind of moved beyond that now. Everybody seems to know that you have to stimulate the breast every 3 hours or you will not make enough milk. And some people are like, oh, okay, can I do it every 6 hours? I'm not too worried. The problem there is if you do that, the breast is so receptive. And remember, it's that unit that knows what it needs. We only give that input every, 4 times a day, the breasts are like, oh, this might be an older baby. Maybe I don't need to make that much milk. And you will very quickly lose the ability to have the amount of milk that you want to have. So that's the key thing to know, that you have to remove milk from the breast every 3 hours.
Can I ask, is that also, say you've got one of those unicorn babies that sleeps overnight for 5 hours, are you getting up at 3 hours in that time to pump?
I don't want, pumping is a whole other thing, right? But I don't want to, there's never a uniform rule. It really depends on your baby. So if you have a 2.5 kilo baby, which is wonderful and perfect, and many, many people have 2.5 kilo babies. But if they're jaundiced, if people are a little bit concerned, if we're having decreased urine output, then yes, we would recommend waking that baby every 3 hours. And this is not a blanket rule. You have to do it in with your medical advice and nursing advice. But generally, we're going to wake that baby up. If it is the baby that is, came out at 4.2 kilos and had no health issues and is gaining weight and is completely fine, then I would still say no longer than 1 4-hour block in the evening and then make up for it in the day. And that is to get your breast milk supply. After you have established your supply, that's somewhere between 3 and 6 weeks, then you can completely trust their cues. But until that point, I would say that. And you can have a 4.2 kilo baby that also has complicated issues, and then that baby will have to be woken up as well. So that every 3 hours, the two things I always tell my patients that come in for antenatal breastfeeding consults is, one, you have to remove that milk every 3 hours. And if baby is too sleepy, then we talk about alternative ways of removing that. And then the second thing, and I always feel really mean saying this one, if you get collectively, and I'm probably going to get a lot of hate for this, but if you get collectively 3 hours of sleep at any time in the night, you're doing well. Let's hope you get more. But if you have a reasonable expectation of how those nights are going to go, you're not going to feel like I'm doing something wrong, or there's something wrong with me, or there's something wrong with my baby, or everybody else is sleeping more than me. If you are getting 3 hours, that's great, and you're doing really well.
You mean 3 hours consecutively? No, you
I don't always. No. Yeah,
3 hours.
It really depends. It really depends on the baby. So some babies will like feed and go to sleep, and that's it. Some babies will feed, fall asleep every 5 seconds in those first few weeks, and you have to wake them up. And you're constantly waking them up, and they're very slow feeders. And by the time you finish your feed, it's 40 minutes, and then they may do a poo, and then you have to change them, and they get unsettled. And this is just the reality of what happens. And the more people know that that's a possibility, the better it is. But if you have the alternative of a baby that fed, awesome, efficient, got that milk in, didn't poo, then that baby, you're going to get like a nice 2.5 hour gap possibly. But yeah. So,
and this is why mothers in their first 6 weeks need to be just cocooned and supported, and not raced back to work, and not raced out to the friend's 30th or whatever. This is tough.
There's so many reasons for that, actually. So I did something about that recently, about that postpartum expectation. So before my days of breastfeeding medicine, I was doing peds, and we would in the neonatal ICU and sometimes in the PICU and things. And it's awful when you see these 2 and 3 day old babies come in, with things that they caught from being out. But society is like, oh, look at you, you've recovered so well,
you're out and about.
You're out and about, and you should get out there. And again, it's that false pressure that, your body is still doing absolutely incredible things. And leave on your body, your brain. A lot of cultures have something that in English we call the confinement. But what's really interesting, all of these other languages, and even actually a lot of the Anglo-Celtic languages, they all, even in their old, in ancient Celtic languages and things, used to have terms, but they all were healing for the mother, lying in, recovery, support. But somehow in modern English, it is the confinement.
Yeah, we ended up with confinement. How awful.
Confinement, right? Which is such a restricted word. And again, puts a negative connotation on, oh, I'm not going to do a confinement, I'm a modern person. But it's so protective for and it doesn't mean you have to voice yourself and not see anybody and do anything, but it means don't put pressure on yourself to be, hosting people or having people come over, or, make yourself walk if you're not ready for it. Just take it easy and respect what your body has done, and give yourself grace. Yeah,
I went to a wedding when my first boy was 3 weeks old, and it was fine, but it wasn't the right thing to do back then. But it's only hindsight that I now really think that those 6 weeks, at least 6 weeks, should be just reviewed and somebody supported to recover.
I was the same. I was like I told you, I wasn't sure about having kids and things, and I was a very adventurous, like exciting, like I was still that like 34-year-old, like out in the clubs, like being like, I'm too young to settle down and have children, right? Yeah, that's who I was. So before I got pregnant, we had just gone and done Mount Everest, and we'd done the base camp.
Wow.
And I'd come back from that, and we had decided, we were like, oh yeah, we'll have everyone over and we'll have a little barbecue. Okay, had a 6-week-old. And I was like making Nepalese dishes, and I thought this was going to go well. And I actually just forgot to feed the baby. I had a baby that was would forget to feed. It had been 6 hours, and it was just a disaster. And our friends were all really great supportive, but most of them had kids. It was just such a shock to me. And then after that, I found that I couldn't really. I wasn't able to manage socializing and looking after a baby. I'm very like intense, So it would be like if I'm with people, I'm what baby?
Yeah.
And
there you go, people. You've heard it firsthand from a medical doctor. This is what happens. My second boy would just fall asleep everywhere, and at one point we were moving, and everybody left to get the next load, and I went, oh my God, where is the baby? And I'd put him in his little bucket. I used to call his car seat bucket a bucket, and I'd put him in one of the rooms and forgotten that I'd put him asleep in one of the rooms. I'm sorry, this sounds dreadful. What a dreadful mother.
But it does. How? Like you should like when you think about what the pressure you were putting on yourself, and it's important that people know this. I have another few patients that I've seen recently who are moving and doing other things, and they're wondering why they feel like having a meltdown, right? Like anybody who's trying to do these things when you're postpartum, look, we're both down the road, and I am not like I'm barely keeping my head above water with all this stuff. So when you're a new mum, it's you can't expect that of yourself. No. And also, they need to know that their brain is structurally changing, right? And
for the better. Like often we hear that it's for the worse, but come on, it is for the better.
Oh, it is for the better. But also, anyone who tries to imply it's for the worse is using a standard that I think is useless and is kind of defunct and stupid. To be honest, like what makes you better if you can remember where your kids are and stuff like people's names. People's names, right? Like I don't think people stop and understand that the brain doesn't structurally change. It just doesn't change after you've done your development. It can deteriorate, but you don't grow new pathways. That just doesn't happen in life. And what happens after you have a baby is you develop new neural pathways in the hippocampus, in the amygdala, which lead you to different skills and completely different things that you were not capable of doing before. And it doesn't happen if you don't have a baby. And you can miscarry and that still happens. You still have those brain changes. So I want anyone who's listening to that thinking it didn't happen, you still changed, in that fundamental way as well. So if you feel different, it's because you are different.
All right. Well, so in your 3-part series, we've talked about knowing the breast and then knowing the baby.
So what you have to know there, the second thing that you need to know is how is that breast milk made? So yes, we know we have to remove it, but what is the important thing? The important thing is that stimulation of the nipple, and it has to be a good vacuum applied. So if a baby's sitting on there and is falling asleep, that's not going to be effective. They have to actively suck. If you find that they're not sucking, then we need to express. And that can be, in the early days, we can hand express because we don't need that much milk. We have lower volumes in those first 3 days because it's not that you don't have milk, you have colostrum in those first few days, right? And then the transitional milk comes in. It's really important to know that there's a three-step pathway. There's nipple stimulation, then that sends messages up to your pituitary gland, where you then release prolactin, and then the prolactin goes back down to the breast, those glandular, those cluster of grapes, and will lock in there in the prolactin receptors in the lactocyte and signal that lactocyte to make the milk. We actually make milk in no lactocytes, and we can get some things from the maternal bloodstream, but a lot of the awesome components are synthesized there. And again, then we have to remove that milk. So that cycle has to keep on continuing. It's a feedback loop is what we call it in medicine, which means if we don't have stimulation, then we're not going to get that hormone rise. We're not going to get that going to the gland, and then we're not going to make it. So that's what has to happen. And then the third part is understanding with babies, how does that milk transfer from the breast to the baby? Once you stimulated it effectively, how do we get it into the baby? Now, if baby goes on and latches, which is not the common experience, okay? If that happens to you, I'm so happy for you, and that's incredible, but it's just not the common experience. What has to happen is the baby has to be supported so that they can use that vacuum. This is the one where I get people to, you've got a glass of water there?
Oh, yeah, I've seen this. You did this on one of the podcasts that I watched.
What you need to is how babies drink and how we as adults drink, because what will happen is people will come on and try and shove the baby onto your breast from the back of the neck. But what I do, if you're in my room, I show you how that feels. But even if you do it now to yourself, hold your neck and keep it still. Okay, keep it your head nicely flexed, so you've got a 90-degree kind of thing. So you're not allowed to do this. Mm-hmm. Okay, now try and swallow.
Hard.
Difficult, right? Mm. So we can only swallow when we extend. Okay, then the next thing is, now tighten these muscles here on your neck, the front of your neck. Okay, now try and swallow.
Well, I can't even do that. It doesn't work.
So, and that's meant to represent the fact that we know the babies have a weak neck. So if their neck is not supported adequately, they are not going to be able to use their mouths to exert the vacuum. So much of latch is being able to support the infant. And if you understand the infant and what they're capable of, and I don't mean in a deep way, I mean this is a newborn baby, they don't have neck control, they have weak necks, but they have great sucks. So we just have to support their ability to create that vacuum. Then we won't be able to create that supply.
Mm. It's difficult to know if you're not doing the flipple or you're not doing the hamburger or whatever. How do you actually get the baby to take the amount of nipple or areola that they need to make sure it is a good latch?
So again, the pressure's been put on you, whereas what we forget is that babies are born with these innate reflexes, right? And even if yours is a bit sleepy, they've got the reflexes. It's about encouraging it. So if you put them in the crook of your arm there and bring them to the breast, and so this is always what my patients find the most shocking, is that when they come in and it's like time to feed, you can see them almost like getting
panic.
They're like, they're panicked. Body is hunched. Okay, oh my God, here we go. And it's not like that. I'm like, the first thing I do is like, okay, sit back, scoot your bum down, get comfortable in the chair, put your feet up. I have a little footstool. Ideally, you'd have your legs all the way up, but we put our feet on the footstool and we sit back. And already that's telling your body to calm down, right? Then we get the baby in the crook of the arm here, in the cradle hold. And we bring the baby to the breast, but we're not going to shove anything. We're not under time pressure here. We're letting baby work itself out. And then we optimize the position of the baby and the breast. So sometimes we need to bring them across the body a little bit more. If you've got larger breasts and your nipples are pointing out that way, we might need to move our hand this way, but we keep them in this position. And they will, it's remarkable, they will open their mouth and they will, try and find it. And then we just support what they're doing, support their anatomy. But we support it by following the principles of latch, which are all outlined. Do you want me to quickly go through those?
Yeah, I'd love you to talk about what are the principles of latch.
Okay, these are principles of latch, and some of this, the one I learned from Robin Thompson was about the importance of this cradle hold. Okay, so that's the first one, the cradle hold. The second thing is the chin deep in the breast, on the inside of the breast. So if you're feeding on this side, we're going to put the baby here. If you're feeding on this side, cradle hold here, baby's here, and you're going to bring the baby across there. And I have patients with short limbs and different things, and the length of your arm does not reflect the ability to do this. Then we need to bring the baby up very close, so tummy to tummy is the fourth one. And then we look at the baby's mouth and face, right? So this is another Robin Thompson thing, which is about cheek to facial symmetry. So you want your cheeks to come flush on the breast, because if it's off the side like this, the nipple is going to hit the hard palate over there. If it's down like this, it's going to hit the hard palate, and that's how you get those nipple abrasions that you were talking about earlier. I have somebody come in, which is every day, and we fix that nipple pain. I get so happy for that patient, but at the same time, so devastated that it's so simple, because it's micro movements. they're almost there. And it's literally like we just have to shift across this way. Bring the baby in, allow the baby to tip the neck back, and then we get a pain-free latch. And I always get my patients to film it because, of course, when you go home, you won't remember it. Because But the person who is standing watching you is actually the person who's most helpful. So often the dads will come in and I'll be like, they'll sit down and they'll be like, oh, yeah, it's the doctor and the mom's time now. And I'm like, no, up next to me. And you need to watch. And then I get them to, if the pain comes back, I was like, what do we need to fix here? And then they'll say, oh, we need to lift the arm up. We need to, move the baby across, bring the baby's not tummy to tummy, all of these kind of things. And it's actually amazing to watch because it involves them.
Can I ask, when you're doing that, sometimes, I'm putting on Belinda, our physio's hat here, where she does deal a lot with people with, upper shoulder trapezius kind of pain from breastfeeding. Do you work with people with a breastfeeding pillow, or what do you think about supporting that arm if they're getting tired?
So that's what I want you to do at home. While the baby is small, when they're older, they can support their body. So this is not forever. This is just for those first 6 to 8 weeks while they're developing some strength as well. So I always say to have this arm supported with any pillows you have in the house. And you might have to use 2 flat pillows. You might have to use 1 fat pillow, 1 skinny pillow, and try and support the arm and baby. So that's what's doing that way. And then also you need to support the delts over here as well, because you're using the reason why most people struggle. I always say, would you expect yourself to do 3 cartwheels, like perfect cartwheels? You wouldn't, right? And the same way, we just think we're going to be able to hold babies and know how to hold them and know how to read them, when for most people, they've never held a newborn until the day they have their own. And even if they have held them, they've never spent 2 hours with them.
It is different, isn't it? I want to talk about, as the babies get fuller and sleepier, I don't know whether this is just my babies, but what they would do is, they'd be belly to belly to begin with, but as they got fuller and maybe I got more tired or whatever, then they'd sort of roll off and have that, I'm a very happy baby, full baby approach, but they're still hanging on to the nipple. And from hindsight, I think maybe I was creating some nipple damage from not being attentive to the baby being belly.
Look, I think I didn't see you at the time, but I doubt it was one thing that you were doing that caused it. Most likely it was something in that original bit that the nipple, you would get the nipple abrasion from the nipple hitting the top of the hard palate. And that's not going to happen just because the baby does a few sucks at the end of a feed, because they don't put the vacuum on them. So they're not putting that same force on them. So it was probably a few things with just the positioning that was going on there as well. So don't feel like if I had just done that, I would have stopped the pain, right? Yeah, so it's very natural and normal. This is a really important one for people to know that babies are supposed to fall asleep on the breast. That's the way they're designed to do things. I mean, it's not. We may not like it. I couldn't stand it when it happened, because I hate they go from this active sucking to that butterfly suck.
I love that butterfly suck.
Oh my god,
so cute!
It's so cute when they do it and you're watching it, but I just couldn't stand that sensation. I just was. But I think as well, I just wanted them off me as well, right? So at that point, if they're doing that butterfly suck, you can delatch them. They might get mad. It doesn't mean that they're hungry. It just means they want to get that comfort back in their mouth. So you can take them off, but you can let them also fall asleep at the breast. So it's really important for people to know that that's the ideal way for babies to do things, to fall asleep as well. All this other stuff about putting them down drowsy, there's no science behind that. It causes stress and it's unnecessary, And there's also things like, there's tryptophan, which is a precursor to melatonin in the breast milk that you make. There's also cholecystokinin. There's all these things which support infant sleep. So that's why they fall asleep.
Hit that arvo slump and fighting to refocus? Everything feels harder than it should. I'm Claire Murphy, and this is Well, your weekly wellness reset. No fluff, no fads, no woo-woo, just clear, expert advice to help you bounce back to your best. So whenever you need a second of self-care, join me and our resident GP, Dr Mariam, for real talk on our bodies, minds, and how to live a healthier life. Listen now, wherever you get your podcasts.
I don't know whether it was just my family, but my mum told all of her girls that you must burp the baby. And my babies could burp for Australia. They were champion burpers. And so if they've fallen asleep on the breast, can you tell me whether A, burping is necessary, or B, if it is, then what do you do if the baby's fallen asleep?
So burping is a big one. Lots of information and misinformation out there about burping. Other really important thing here is that there's not a one-size-fits-all for babies in anything. So there are some babies that have to burp and have to be burped. There are other babies that don't need it. And so much of that has to do with the way they take in the milk. So actually what causes the milk, there's always air in the stomach, right? But like even now, if you swallow some air, like swallow it, do you need to burp?
No.
Right? Yeah. So and the other thing that people don't know is that when you're breastfeeding, you're not getting any air. Donna Geddes and the team at UWA, Sharon Perella, and all these amazing people have got really definitive studies to show that under ultrasound, when you're watching the sucking, that baby is not getting air when they're drinking milk. And I think it's what people don't realize, that you can't breathe and swallow at the same time. So you can only do one or the other. So there's a lot of misinformation there. What causes the need to burp, just like us, is if the stomach is filled quickly. So if you and me both just gulp back whatever we've got next to us, we might need to burp. It's stretch receptors in the stomach. So if your stomach is filled really quickly, then you might suddenly need to burp. If you take your milk slowly and your baby's regulating what they're getting, because they don't take a whole volume, they can regulate it when they're breastfeeding. So the tongue, when it goes up, we've got vacuum. When we go down, it's released. And so they can regulate the volume and the flow a lot of the time. I didn't want to complicate it, but when you were saying nipple pain, fourth baby, all of this, I bet you had a fast letdown.
That's exactly what I'm going to say. I know why my boys had to burp. It's because my fast letdown, I would finish the feed. They would finish the feed in like 5 minutes flat. It was just such a fast operation. I never had that lovely, calm time that people talk about where the baby's just sort of snuggling on the breast and stuff. It was business. And like, I remember in my first baby, the milk came down so hard and fast that it would literally come out his nose. So he was kind of drowning under my milk. Yeah.
Yeah. And that's also, when you were saying that, about the pain that you had with that fourth baby, we have more glandular tissue with each subsequent pregnancy as well in our breasts, right? So you can see that there is more milk and more milk quickly. So this baby, again, I wasn't there, so I don't know, but one of the scenarios, if it wasn't a latch issue, is that this baby was trying to regulate the amount. And if somebody's, if you're guzzling things, he might have come off onto the edge of the nipple, and he could have been chomping on the base of the nipple. So if that was the nipple damage you had, it was most likely actually that the milk was just coming too fast and we had to just slow that down. Yeah. Is that what was happening?
That's exactly what was happening. So if somebody out there who's listening to this episode and has a big fast letdown, what are some of the things you can do?
Okay, so for the first 4 to 6 weeks, we're not going to do much about it, right? Because we need to see that consistent weight gain before we alter or change anything. The fast letdown, sometimes it's a physiological response. Some people just have a fast letdown, but sometimes it's a pressure-dependent thing. So the way that milk comes out of the breast, it's pressure. So if you have full lactocytes, there's an increase in pressure and you apply that vacuum, it'll come out really quick. If they're less full, it'll come out, but it will just come out slower. So that is the reason why we wouldn't do anything about that for the first 4 to 6 weeks, because we just don't want to mess up your supply and your volumes and let that regulate. After we are sure that baby has consistent weight gain, which is the 150 grams per week in the first 12 weeks, then we can think about things. So often what people are doing, maybe you don't have to do both breasts, and you've got to be guided by the baby. This is what you must do, this is the answer. It's always it's very individual. This is the interesting thing about breastfeeding medicine as a specialty. You have to be able to look at 2 people and 2 systems. If anybody tells you this is the answer just by looking at the baby, they haven't done you or the baby justice. If anybody tells you something just by looking at you, they're also not doing, because some babies can cope with that flow, some babies can't. Yeah, so the old thing that I used to say as well is you lie back, but we now know that physiologically it doesn't change that that reflex. It's like saying that the way our heart pumps, like it doesn't change necessarily when we're lying down. So these are cellular things that will release no matter what. People are often pumping as well, and that is artificially increasing the supply. And people may not realize what pumping is. It doesn't have to be a wall plug-in pump. It can be the silicone catchers. They exert a lot of suction on the breast, constant suction on the breast. And there are times where they're really useful, but the vast majority of people are using them and creating an oversupply. So we would alter what's happening there. But even the ladybug, I like the ladybug collectors, but even if you apply it on there's a little suction thing on it. If you apply that on, then that's putting suction and artificially stimulating supply and not just catching the letdown. So altering any kind of pumping, getting rid of any pumping will also help with that letdown. The third thing that I do, and which is really hard to explain if people are listening to it, is that we use the kind of web between our first and second fingers. We would gently put it on the breast around the areola there. And we're not digging in, we're never putting point pressure, like fingertip pressure on the breast, because it's glandular tissue, we need to respect it, We're using just general pressure to stop the flow of milk, because the milk ducts are very superficial to the skin of the breast. So gentle pressure, just like we'd compress a vein on our hand, and we would do that on the breast, and you'll still be getting milk out of that side, right? But you can't see my hand.
No, I know what you mean. Yeah. So
But this side, there's we will reduce that milk while baby is slowly taking that milk in, and you will look at baby. Just doing this itself isn't the thing. If baby is spluttering, coughing, milk dripping down, sometimes clicking, we know that there's so much milk coming out quickly, so we can try this. And then you'll see they'll slow that breathing down, okay? And then if they start getting, you'll see what's the word? Furrow, right?
Brow.
The brow furrow. That's what I was trying to say. You'll see that happen, and that means, they want to get some more. Then you can release it, let them have it, and then if they start that, there's a very typical kind of, that panting sound that they do. Just like us, if somebody keeps giving you lots of, liquid, it's the same. Those are the three things to do, but it's always look at the whole situation first. Are we creating an oversupply through behaviours, or is it something that we're doing mechanically? And the other thing you see commonly, second babies. People will accidentally cause this. I did it with mine. I didn't know about any of this stuff, but because my oldest would wake up if she made a noise, it was like, and sometimes, and I'd be out, I would just want to have a conversation with somebody. So I'd be like, I ended up feeding her a lot.
Is there a problem with overfeeding? Like, is there a problem with putting the baby on the breast all the time and using kind of like yourself as its soothing comfort as well as feeding?
I think what you might be asking as well is it creating any emotional issues or problems or anything for mum or baby? Is that
not necessarily? More to do with, some people say overfeeding causes colic or, discomfort for the baby. I don't know. I was a big fan of the dummy. So
so I don't have hard rules about anything in breastfeeding medicine. So for babies where there is a fast letdown and an oversupply, yes, but this one we need to talk about properly, right? So I need to go into it properly there. So because it's a complex pathway. So we don't want to introduce the dummy too early, but if your baby needs to suck and they're struggling to cope and they need to suck for everything, for pain relief, to help the milk pass into the gut, then the dummy can be very useful. So in a lot of these babies that are coming in, having lots of spit ups, having, periods of crying, I'm talking about babies after 6 weeks and things like that, then the dummy is super useful to help them kind of manage that pain and to suck and to that suck reflex, because they don't get enough time to suck because these babies are full within a couple of minutes. So it can be used like it's a tool to be used. And the key thing, though, to know is that all those little cute dummies, they're no use. You need to get one that, those like long kind of bulbous, the brownie kind of material one. I think right now we only have one brand that does it. I'm not allowed to talk about brands, but anyway, there's only one that has that kind of long bulbous end. But that's the key when they're having a dummy, because a lot of times people come in and say, they won't take a dummy, and I'll say, bring it in and I'll show you how to take it. and we can use that to get that break, because when babies are screaming, it's very hard to put them down.
I've a memory where, you know, one of the babies would be a bit unsettled, and I'd put a dummy in, and after a couple of sucks, they'd do an enormous poo. It was sort of like it was so connected.
Correct, yeah. And that's the thing. Like, that's why it takes, like, it's really good instincts you have, right? Because all of what you're saying adds up to me. And lucky you had those instincts and listened to them. So everyone has the instincts, but they don't have the confidence to listen to them, you know? I was kind of a bit careful to say we don't want to bring it in too early because of the supply, and because often, like even yesterday I had baby in, and the baby started to, fuss, but it was playing. And this is actually a 6-month-old. And they were like, oh, yeah, put the... And I was like, no, if the noise doesn't bother you, it doesn't bother me, right? Let the baby... So for that, maybe that's not the ideal use of the dummy. But if we're using it to help them with pain, help them process their food and comfort and all of that, and sometimes these babies, you know, they want to suck to sleep, but if they suck on the breast, they're going to get too much milk again, and it's a never-ending cycle. So
does colic come from overfeeding a baby?
So colic it's not a medical diagnosis. It's a term that we use to describe some symptoms. So what the definition is at the moment, according to all the paediatric guidelines, is it's if baby has 3 hours of crying for more than 3 nights a week for 3 weeks. That's what we call colic. My personal view and the science is that babies don't cry for no reason. We may not always understand the reason, but when they're crying like that, there is discomfort. In a baby that is gaining weight well, at 150 grams per week, if they're gaining more than that and they are having these excessive periods of crying, oftentimes it can be that they are processing too much milk too quickly. And they, just like you and me, if we were out and we had a great meal, and then an hour later, you know, we have another, you know, great meal, and then an hour after that we have another, you know, pizza, and then 2 hours later, you know, whoever we are, it doesn't matter how great the food is, we're going to be in pain. We're going to be curled up on the corner in pain. And that's often what it is for these babies. And that you'll see them. They'll do it even on the breast, these babies. They'll wriggle and stretch and they'll tell you. And often because we're so paranoid about them feeding, you'll try and put them on the breast when they're giving you clear signs like, I can't have this now. So colic is something that I think in that situation where baby is gaining weight well, then we need to have a think about, is there something that could be causing gut inflammation? And now that sounds serious, but it's not. It just means like the gut is processing too much milk too quickly.
Kavita, we have covered so much, and yet I know that there's a whole mountain to go. Like, you know, there is so much information here.
Yeah, I wrote notes down for all your questions. I'm like, I didn't even get past the first one.
That's all right. Maybe what we could do is a quick, rapid-fire truth and myth. How do you feel about that?
Okay.
All right.
Okay, I love it.
A baby with a high-arched palate can't form a good seal.
Myth.
Myth. There is such a thing as foremilk and hindmilk, and a mum must remove the foremilk to get to the hindmilk.
Absolutely.
Oh, a baby with a tongue tie can't breastfeed.
Myth.
You're like, I can't do it. Did you say myth?
Yeah, I said myth.
You've already answered this. A flat or inverted nipple prevents you from breastfeeding?
Big myth.
Love it. A breast needs to be drained during or after each feed.
Myth based on dairy cows, and we don't have breasts like dairy cows. We have breasts like pigs, which is a ductal system.
Oh, love it. Everyone should have a silicone milk collector.
Myth.
Great. Do tongue ties exist in the first place? And what do we do about them if they do?
Absolutely, they do. Every human that has a functioning tongue has to have a version of something that's tethering it to the base of the mouth. The frenula exists in everybody. That's how we can literally, you know, do all of that. The question is, does it restrict breastfeeding? That's what I am knowledgeable about. Occasionally, yes, you can have frenula which are restrictive, which can impede the latch. But the majority of them do not. If you understand the principles of latch and how to support baby, they do not impede the ability to latch. Nobody is trying to harm people. I think people don't realize when a mum comes to you crying, you want to give them a solution. I was in the clinics when we started doing them at the women's, and it's nobody is ever doing anything to harm, I believe, right? So people want to help. But the problem is a lot of the people who do the revisions don't do the follow-up. So that's when they come to me. They've had one revision, they've had multiple revisions, and they're still there with the issues. And even when I've done a few polls, and this is absolutely not reliable, but I've done anecdotal kind of polls on my things, it's like how many people felt it improved. The thing is, if you have a tongue tie release, it should improve the function of the tongue and the baby's ability to latch and cause a pain-free latch should improve within 24 to 48 hours. That's me being generous, because the muscle is not restricted, the cheeks aren't restricted. We're just saying that this frenula is preventing the tongue from going up and down and doing that. That's all it needs to do. It doesn't need to do anything else. So that's the key thing for people to understand. If you understand the function of the tongue and what it needs to do and how to support the baby's intraoral muscles, because the vacuum is created by these muscles, your cheek muscles, all of that, right? You'll realize that tongue ties are wildly overdiagnosed. Everybody has them. And but the question is, do they need to be cut? In the last 2 years, I've referred on two to be revised. And both of those actually were breastfeeding beautifully. I just got intimidated because they had heart-shaped tongues, and I've still followed them up, and that baby still has a heart-shaped tongue. So I'm like, did we refer it for the wrong reason? But I was so concerned that it was so restrictive that it may have caused issues later on, but it wasn't impeding the breastfeeding. And this was like the grade 1, the division in the middle of the tongue.
Wow, that is.
But there are some people who will need it. Okay, so I don't want to invalidate those people who do need it. But when you were saying about the foremilk and hindmilk, right? Foremilk exists, hindmilk exists. The foremilk is so valuable, it's so precious. I'm obsessed with the foremilk. Okay, so it's and the content of the lactose. This is what everybody thinks it's too much. Lactose stays the same throughout a breastfeed. In the hind milk, where you've got this supposedly wonderful, creamy, rich milk, the lactose content is still 7.3%. The fat content does increase, but it goes up from maybe 3.8% to maybe 7%. If your baby gains weight, because it's not because you're giving it the hind milk, it's because you're feeding for longer.
Thank you. No, that's perfect. Yeah. Breastfeeding is just one of the many things that, society puts pressure on women who are having babies and growing the next generation. But I just wanted to talk about one thing that I found lately in socials is about this thing called a breast crawl. Like, things like that, are they necessary, or does that just make people feel less than because they can't do it?
Yeah, so this is a big complex one. I'm glad you asked me this. Rather than looking at one particular thing like the breast crawl, right, I always think about the framework of why do we feel like failures? How has that come about? And I think we touched on it earlier, but I think we've got to look at the structuring and how we look at motherhood, how we look at ourselves. So it's actually a societal problem. If we feel like we have failed at something, I hate that word, but if we feel like we've failed at something, we've got to look at the apparatus that has made us feel like that. I know that's a bit of an esoteric answer, but I think that is the key to it. I always say to people, they'll come in and say, oh, I didn't manage to do this, or I wasn't able to do this. And I say, no. Because I told you before, words matter, language matters. It was you were not supported to do this. You did not have the knowledge, or you did not have the generational knowledge, and we did not have the societal knowledge. We didn't have the medical knowledge. So that is the only reason why mothers, parents aren't able to meet their goals. And I think whatever you feel upset about, whatever is upsetting you, I'm absolutely not saying don't feel your emotions. Whatever is upsetting you, please reframe it as to how did I get to this? How are we all in this position? Because it's not you. Everybody feels like this. And I think that's a really, really, really important thing. I think it's more important than anything else.
Oh, I love that. Even us talking about my hyper lactation, I'm sorry, I've made it about me, but now I understand that even from our brief talk, I always thought I was a bad breastfeeder.
I heard that in your tone, and that's why I actually got distracted when you were saying that, because you weren't you didn't have the knowledge.
No. And that's, I'm lucky. I've got Dr. Pat, and he just says, no, you breastfed like a champion. Like each kid got up to at least 6 months. Like that is amazing.
Amazing.
So,
and any amount is amazing. And parents need to know that. Any amount is amazing. But I can see it still gets to you with that last baby, like what happened. It wasn't something that you missed or that you didn't do. And it's important. I'm glad you brought it up. And because when you personalize this, people realize that the other things and how common it is. It's not out there that it's common. It's not out there that the reason it's common is because it's completely ignored. I think every mother is amazing, no matter how they fed their baby, no matter how they sleep. And I really, really mean that. I hope people understand that.
And how, as a society, we could be supporting women, even from our family unit. So I wouldn't be the only mum that their mum has said to them, oh, maybe you haven't got enough milk. It's such a common thing. Yeah.
And that's what society, medicine, politics, they don't understand how deep this is. Like, I can see you're emotional about your kids are fine. They're grown up. Like, for you, this is still in there and deep. And that's actually why I got into this. I love breast milk, but that's not why I got into it. I got into it because I couldn't handle seeing women feeling like this every day. Every day women are crying with me. And the reason is because they're made to feel less than in all of that, And if I get them before they're pregnant, I have a breastfeeding plan, and I put a section there where they discuss it with the partner, because I'll send it to you guys too. But it's really important that the partner knows what your goal is, because then they will support you. Otherwise, they feel like, and I always ask people, why do you want to breastfeed? Is it society? Is it your mum? Is it your sister? Is it your best mate? What is the reason? To make sure it's something that you actually want and is important to you. So, yeah.
Oh, that's great. Can I have a look at that plan? Like that?
Yeah, I'll send it to you. Yeah, I'll send it to you. Yeah.
All right, Kavita, I think we might wrap it up there. There is so much, and it's so dense that people will have to maybe have a couple of listens to this episode. I know I will. But I thank you so much for your time. That was incredible.
Thank you so much for having me. Love chatting to you.
All right, everyone, thank you so much for joining part 1 of Kavita's talk about breastfeeding. We did get onto some more bigger topics, and that is how can we change the world for postpartum families. I love it. I love her passion around there. So I hope you did too, and stay tuned, because part 2 will all be about mastitis, and I think everybody should be listening to that too, whether you've got mastitis or not. Let's help prevent it. All right, until next week. Thank you so much. Have a great week. We'll be back in your ears next week. Hey, even though Dr. Pat is, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.
Parenting podcasts can be a bit earnest. Parenting Out Loud is not that podcast.
This person who I may not agree with politically is trying to talk about integrating children, not just into his professional life, but into public life.
I have referred to myself as one and done. That article did make me rethink the term.
It took about 11 seconds for this to go viral.
Oh God, is this the ejaculate one? That is deranged, and I love it.
Parenting changes the way you see everything. Parenting Out Loud takes the big conversations of the moment and puts them through that filter.
Because if parents are thinking about it, we're talking about it.
Parenting Out Loud. Listen weekly wherever you get your podcasts.